Let's talk about tracheal collapse. Tracheal collapse is fairly common in older small breed dogs. Tracheal collapse is divided into two different problems. So the tracheal collapse that we typically think of is where as the animal ages, the cartilage, which is what makes the windpipe, the trachea, it's flexible but sturdy. And as they age, the cartilage deteriorates and becomes flimsy. So when you breathe in, you create negative pressure, and that negative pressure collapses the trachea. If the cartilage is normal, then it won't. But if the cartilage is weak, then it will collapse on itself. As it collapses, you get less air. You feel that you need to breathe, you need to bring in more air, you get more desperate, more negative pressure, more collapse, and that's how these dogs present to the ER in respiratory distress. Also, as they breathe and both sides of the trachea hit each other, that triggers inflammation and coughing as well. So this is the typical classical tracheal collapse. But you also have these dogs that have what looks like tracheal collapse, and they develop symptoms at a much, much younger age, or at least perceptible symptoms. And these are what we call tracheal malformation. So instead of the rings having this U shape, one or a couple of rings have a malformation where it creates this indentation into the trachea, creating this W shape. You know, sometimes you get patients, they get referred for a tracheal foreign body or a mass in the trachea when they just have tracheal malformation. So if a Yorkie presents for a tracheal collapse or a tracheal mass or a foreign body when they're like 6 years of age, I bet that patient probably has tracheal malformation until proven otherwise. There's some characteristics in the radiographs that we can tell them apart. We treat them the same way. So when you have tracheal collapse, whether it's malformation or the conventional type, you want to improve symptoms. You can't do anything, or at least you don't do anything initially from the mechanical aspect of the trachea, so you try to keep them calmer. You want to use antitussives, sometimes anti-inflammatories. Weight loss is helpful, using a harness instead of neck leads. All of those things are helpful. But the problem is that this progresses, one, it progresses over time, and then two, is that if you have a trachea that's very collapsed or a very severe malformation, that patient has a lower capacity to bring in air, right? It's just a mechanical issue. They can't bring in as much air sometimes as they need. So the keeping calm, your body uses less oxygen, versus if you get excited for whatever reason and you breathe faster, more negative pressure, more symptoms. And the biggest worry that we have in these patients is that they could develop respiratory distress and not come out of that respiratory distress. And the only way to try to prevent that from happening or addressing that if it were to happen is by mechanically fixing the trachea. If you have what we call extrathoracic tracheal collapse, you can place these rings around the trachea to keep it open. The problem is that this is not really effective, as more rings get affected because this tends to be more of a diffuse disease. Thus, other areas of the trachea are going to need to be addressed. And so tracheal stenting is what we can do for these guys. So it's basically this tubular device that you place within the trachea. You don't need surgery. You don't need any incision. We anesthetize these patients. We go through the mouth down into the trachea, and it's a self-expanding stent that opens within the trachea. And so when you breathe in, even if you create a lot of negative pressure, the stent will prevent the trachea from collapsing on itself. There are lots of places that offer tracheal stenting. And I typically tell owners that tracheal stenting is the easiest as well as the hardest procedure to do. The easiest is because anybody can pop in a tracheal stent. The hardest is because you have to really know what you're doing in order to do it right. And the reason I say this is that in order to measure a tracheal stent, you anesthetize the patient. You have to figure out what the normal diameter of the trachea is. So you create positive pressure so the trachea expands, and as the trachea expands, then you can measure the trachea size. There are many different sizes of stents. These stents are fairly expensive, so very few places will keep a large stock of stents with every possible size, so you best size your dog. And as you size them, you have to also calculate, because the length of the stent, you want to try to stent the entire trachea, and the length of the stent will depend on the diameter of the trachea, meaning that the smaller the diameter, the longer the stent will be, and as you increase the diameter, the length decreases. And so if you oversize a stent, that stent is more likely to fracture, and because you can't remove that stent, then you place another one on top of it. If you undersize, then the stent is going to move around. You have tracheas that will taper off, where the extrathoracic trachea has a bigger diameter than the intrathoracic trachea. Nowadays we have these what we call duality stents, where they have two different diameters for both the inside the chest and outside the chest. And so those are all things that you need to take into consideration. So if your pet has tracheal collapse or has been diagnosed with tracheal collapse, we will always recommend medical therapy first, but as the symptoms progress, then you want to consider tracheal stenting. And it sounds scary initially because there are people doing that don't have a lot of experience, so sometimes referring vets will have a not so great impression of tracheal stents. But for somebody that does this for a living, I can tell you that, you know, when they come into the hospital versus when they leave, it's like two different dogs, right? Like, you can't breathe, then you can breathe, and it's crazy how big of a difference it really makes. Some people will come to me because they want to stop the coughing, and one important aspect is that the idea of the stent is not to control coughing, because that's not the purpose of it. The purpose of it is keeping the trachea open so you don't have increased risk of respiratory arrest from very narrow trachea and decreased airflow. A third of dogs will have improved coughing, a third of dogs will have coughing that is static, and a third of dogs the coughing will actually worse, but that's why we have medications like antitussives to control coughing. And for tracheal malformation, because you have that W shape, you have a lot of pressure against one single area of the stent. So oftentimes what we'll do is we'll double stent these guys. And that also creates more radial force opening the stent, because it's hard to go from a W shape to a normal U-shaped trachea. So oftentimes, if you don't size them well or balloon them or double stent them, they'll have these what we call gutters, which will accumulate fluid and bacteria, and oftentimes they'll need a recurrent antibiotic therapy afterwards. So there are things that you need to address after a stent is placed, and continuing to monitor them for eventual fractures of the stent, unraveling. These things are not terribly prevalent if you did a good job, but it's, again, night and day, right? You're doing this in patients that are having trouble breathing, you're constantly worried about them going into respiratory distress, and now you don't have to worry about that anymore because they have a stent in place. So a lot less scary than it seems, not invasive. They go home same day, but you want to have this done by somebody that is experienced with it and also has a large stock. I mean, for us, we have every stent that is available, including custom stents, and I'm really happy that we have that, because just the other day, we had a dog with really severe tracheal collapse that needed a stent, but it actually needed a custom stent because of the trachea size. And if we didn't have that, then we'd have to compromise either putting a stent that was going to be too big for the intrathoracic trachea or too small for the cervical trachea, and both of them would have led to issues down the road, which we want to avoid. So hopefully you'll find that helpful, and we'll see you next time. Thank you.